Recording in progress. Good evening, honorable members. Good evening to the team of the Council of Medical Schemes, as well as the staff from that is supporting the Select Committee on Social Services. I think we can start. I see that we are only 4 members, but we may proceed in terms of Rule 114. Because no decisions is going to be taken in this meeting. So I just want to welcome the honorable members, as well as the team from the Council of Medical Schemes. We really appreciate your time, especially after hours. And then welcome to the staff that is supporting the Select Committee. Honorable members, Marcel, I will request you to please flag the agenda.
Good evening, Chairperson. Good evening, members, our colleagues from the Council for Medical Schemes, and everyone present. I'll do so, Chair.
Thank you, Marcel. Honorable members, the agenda is in front of us. We are now at the point where we must adopt the agenda. Honorable members, can I get a mover for the adoption of the agenda?
Chairperson, good evening. Good evening, all. I propose that we adopt the agenda.
Thank you, Honorable Breed. Honorable Adriaanse.
Good evening, everyone. I move to second the adoption of the agenda. Thank you.
Thank you, Honorable Adriaanse. Honorable members, the agenda is duly adopted. So we move over now to the apologies. Any apologies, Marcel?
Chairperson, I haven't received any apologies, but I do think some of the members might still be joining as you guys have been traveling for a bit. Thank you, Chair.
Thank you, Marcel. I think they will join us as soon as they arrive. So, honorable members, the next point. Yes, Honorable Makwele.
No, thanks very much, Chairperson, and greeting to honorable members and the staff. Chair, in fact, it was just the apology for Honorable Sibande that he said he will be joining. Just now, he was on the way. And
All
he
right.
will be joining. So I just wanted to register it before the meeting. Thank
All
you.
right. Thank you. Honorable Makwele, honorable members, there's now an apology from Honorable Sibanda that he will join later. Can I get a seconder? Honorable members, Honorable Breed.
Chairperson, I will second that, but I see Honorable Sibande has just joined on the platform. So I don't know if I need to second this anymore.
No, you must second it because he is late. So it's fine. Now, thank you, Honorable Breed. So we are now at the point where we will get a briefing by the Council of Medical Schemes on the prospects and gaps of healthcare access in South Africa. I will give over to Dr. Kumedi. Sorry for not saying the surname correctly. He or she is the Chief Executive and Registrar of the Council of Medical Schemes. Over to you, Doctor.
Thank you very much, Chairperson. I'm Musa Kumede, the Chief Executive and Registrar of the Council. Chair, we are led by the Chairperson of Council, Dr. Mabiba, who is sitting next to me, She will lead the delegation and I will then take it from there. Thank you very much.
Thank you very much, Doctor. Thank you for that. Welcome to the chairperson as well. Over to you, chairperson.
Thank you so kindly, Honorable Chairperson. The chairperson of the Select Committee on Social Services, the Honorable Venice, the whip of the committee, Honorable Mugili, the astute committee members of the Select Committee of Social Services, distinguished guests, a very good evening. The CMS wishes to extend its deepest gratitude to the Honorable Chairperson of the committee and the esteemed committee members for the invitation and the opportunity to brief this august committee on the prospect and gaps of healthcare access in South Africa. As the registrar has introduced me, my name is Dr. Thandi Mabiba, and I serve as the chairperson of the council. I would wish us to have a projected slides.
Chairperson, maybe I'd like to find out if we should project on our side or the secretariat of the committee will project so that we can project if we have to.
I will request you guys to project, please, Doctor, because it
Thank you.
will be more simpler.
Thank you.
Thank you so much. Thank you so much. If the chairperson could kindly confirm if they can see our slides.
We can, you may proceed.
Thank you so much. This projected slide depicts the profiles of the other council members that serves at the Council for Medical Schemes. However, a chairperson with me, as we have already indicated, is the CE and the registrar, Dr. Musa Gumede, who is accompanied by the executive team and the secretariat of the CMS. Chairperson, this briefing focuses on the prospects and gaps in the healthcare access and how our regulatory role ensures fairness, equity, and protection for the members of the medical schemes. I will present the first part and Dr. Gumede will then deal with the second part of our presentation. My presentation will cover the three outlined areas, namely the introduction, strategic outcomes and issues, key strategic priorities and gaps. The Council for Medical Scheme is a creature of statutes established under the Medical Schemes Act, number 131 of 1998, to oversee and regulate the medical scheme industry in South Africa. Without regulation, private interest would dominate, and this will reduce both accountability and access. Regulation is therefore essential for safeguarding the rights and interests of millions of South Africans who rely on medical schemes for access of healthcare. Our legislative mandate is derived from the Bill of Rights contained in the Constitution, particularly Section 27 of the Constitution, which guarantees everyone access to healthcare services, including reproductive healthcare. Furthermore, the Medical Schemes Act establishes the Council and outlines the powers and functions of the Council. These functions are contained in Section 7 of the Medical Schemes Act. At the center of the functions of the Council, as provided for by the Act, is the Council's mandate to protect the interests of the beneficiaries and the members of the Medical Schemes Act. The projected slide gives the granular details of the functions and the mandate of the Council as contained in Section 7 of the Medical Schemes Act. Our vision is to be an efficient and agile regulator, generating sustainable stakeholder value. The regulatory philosophy that you can see on this slide is rooted in the commitment to safeguard the interest of members of the medical schemes while promoting transparency, fairness, equity in the healthcare sector. Our mission is to be an effective regulator. This will be achieved by ensuring equitable access to healthcare and financial protection, as well as by strengthening oversight and regulatory compliance. The Council for Medical Scheme oversees approximately 9 million lives that are enrolled in 71 medical schemes. And as at 2023-2024 financial year, the industry collected about 224 billion in revenue and dispersed about 217 billion in claim payments, with a solvency rate of 43.45%. The industry maintains a healthy financial position. In 2022-23-24 financial year, we conducted 72 consumer education sessions, published 5 prescribed minimum benefit guidelines, issued 10 CMS scripts, newsletters, and handled over 22,000 consumer care calls. These interventions, Chairperson, underscore the progress in fulfilling our core mandate, which is to protect the interest of the members and beneficiaries of the scheme. This slide depicts various stakeholders, including the National Department of Health that you can see on the far left, the regulated entities, and the healthcare service providers. All these role players are tasked with ensuring the interests of members are paramount and that members are placed at the center of the equation. We have 6 strategic outcomes as an entity, and outcome number 6 is the most relevant outcome to the problem statement. This outcome states that we seek to protect and promote access to quality, cost-effective, and affordable private healthcare, financing, and related private healthcare.
Sorry, Doctor, for interrupting, but the slides is not moving on our side. I just want to, you can just check that.
Is it not moving still?
No, it's not moving.
We are on slide 15 now. Can the chairperson see it now?
Yes, we can see it now. You may proceed, Doctor. But I will request the members as well. We have received the slides so we can follow it on our other gadgets.
Can the chairperson confirm if she can see as I move the slides?
It's not moving.
You only see one slide. Can you see now?
No, Doctor, I can't see it moving.
Computer. Can't allow close the video or video.
Chairperson, I could see now because my problem was that the slides did not move, but they've now disappeared again.
Yes, Honorable Breed, we were on slide 15, but it's not moving when she is
Can you-
moving it.
Can you see now this current slide?
Yes, can you try to move it?
Then can you see any slide, Chairperson?
Yes, the strategic outcomes is the slide that I see at the moment.
Can you see?
There's a more there. Should have a lot of things open for sometimes if you have a lot of things open.
So can we do it like this? And I will request the secretary out to do the slideshow or to flag the presentation. Please, Marcel. Can you do it, Marcel?
Can I have so that they can move just the movement on our side, even if they can?
Stop sharing.
Yeah, but let me have the slide moving. Oh, yeah, so that I can follow the slides.
Yeah, he has to see the slide, so you have to close this window. Yeah.
They're moving from my side so that I can continue.
Marcel, can you hear me?
Chairperson, I can hear you. I'm currently having an issue. I'm just trying to see if Tabile is able to assist us. Otherwise, can we follow in our notes while the chairperson presents?
Can the chairperson say something now? Any movement?
Is it not unshared? Can you try to share it again because there's no slides at the moment?
Are you sharing?
Yeah, I'm going to share.
So Dr.
Chairperson, I think
Tabile,
Tabile has shared the
yes,
presentation.
have shared it.
Can the chairperson say now?
I can see a slide now, but I don't know if it's moving because Dr. Tabile have shared it, and I think,
Can you see the next slide, Chair?
yes, I can.
Can you see this one?
Constitutional and legislative mandate, yes. So you
Can you
can
see
proceed
that?
now.
Yes, thank you.
Yeah, thank you.
We have, thank you, Chair. We have covered our constitutional mandate, and we have also covered this one that talks to the members of the scheme being at the center of our mandate. And we have also talked to the vision, mission, and values at a very high level, Chairperson. We spoke to the CMS mission, and we have also indicated that the CMS covers and looks after 9 million beneficiaries. We highlighted the financial soundness of the industry we regulate. We had also indicated the granular details of some of the activities as an entity that we do that seek to protect the interest of the members of the medical scheme. This slide also highlighted the various stakeholders that are part of CMS, and we highlighted that the National Department of Health, as you can see the building there on the far left, as the key stakeholder, and other regulated entities together with the service providers, all of whom work together to advance the interest of the members of the medical scheme. We then noted on our strategic outcomes, and we noted that we have the 6 outcomes, but out of these 6 outcomes, outcome number 2 is the most relevant one to the discussion question. And this outcome states that the CMS seeks to promote access to quality, cost-effective and affordable private healthcare, financing and related private healthcare. So we were then talking to the key strategic issues. And on the key strategic issues, the first item on the key strategic issues, Chairperson, as you may see, deals with the block exemption. The block exemption is a legislative tool to facilitate and enable coordination or cooperation in an industry or sector that would otherwise contravene the Competitions Act for public interest purposes. The draft healthcare interim block exemption was gazetted by the Minister of Trade, Industry and Competition, together with the Minister of Health for public comments in March 2025. The draft reflects efforts to make healthcare more accessible and affordable in South Africa, addressing concerns raised by high private healthcare cost. The low cost benefit, which is item number 2, the Department of Health opened the LCBO report for public comments and invited stakeholders to submit their comments by May 2025. Notably, the Gauteng High Court dismissed the BHF's application that sought to compel the CMS and Ministry of Health to implement the low-cost benefit. The demarcation exemption renewal framework has been extended for an additional 2 years. The regulation delineates the boundaries between healthcare insurance products and medical schemes. The Council for Medical Scheme is actively engaged in a comprehensive review of the prescribed minimum benefits to ensure that all medical schemes members have access to essential healthcare services, while at the same time ensuring alignment with the health market inquiry, particularly basic benefit package and the national health insurance. As an entity, we need a more strategic approach as it pertains to alternative funding model to ensure this long sustainability of the entity. CMS marketing initiative to bolster visibility include heightened media presence, digital marketing, member-oriented publications, to name the few. The Section 59 report was released in July 2025. The report brought to the fore the levels of inequalities that need to be addressed within the industry. The key findings of the report are systemic discrimination, disproportionate risk ratios, unfair practices, amongst others. We are formulating interventions, roadmap to finalize the implementation of the recommendations. The medical scheme amendment bill is an act that is still awaiting the finalization by Parliament. On the strategic focus and access gaps, I am going to pass this slide to the registrar because in his presentation, he is going to expand on these issues in detail. As it pertains to the Section 59 once more, the slide further elaborates on the key findings, the recommendations, and CMS intervention roadmap. I won't go into details in the interest of time, Chairperson. Looking forward, our intervention, Chair, aim to align private healthcare with universal health coverage. We need to expand the designated service provider networks, or DSPs, in underserved areas. Additionally, we need to heighten the enforcement of the prescribed minimum benefits and the handling of the complaints by members of the schemes. Promote preventative care and ensure transparency in billing and pricing, as well as develop equity, safeguards for high-risk populations and vulnerable groups, such as pensioners, children, and people living with disability. These interventions, Chair, are designed to close the access gap and ensure that the private health sector contributes meaningfully to the national health goals and objectives. I am going to end here, Chair, and thank you so kindly for the opportunity. I will then hand over to the registrar for the next presentation.
Thank you, Chairperson. I will move to the next part of the presentation. Basically, I will speak on the gaps and also speak on the proposed methods to close those gaps. As indicated by the Chairperson, the slides I'm going to speak on will touch on the context and the background to the health scenario in South Africa and how it affects private healthcare as well, and how it also affects public healthcare. I will indicate here in this slide issues that indicate inward-looking challenges that we see in the sector. I will also speak on the outward-looking issues. For instance, we receive a lot of issues coming from the public, and they come to us in the form of complaints. These complaints refer to prescribed minimum benefits. Some of these terms later on, maybe we will speak on in detail what they mean. These are tools that legislation has put in our hands in order to deliver private health care so that we do not run out of funds. So some of the complaints are about how PMBs are delivered. Some are clinical complaints about how people have been treated. Designated service providers is providers, how providers are out there in the community are accessible. And also the interpretation of emergency disputes are part of the main issues that come to us. As indicated, service providers are limited, and there are sometimes disputes if you go to the wrong service provider about how you get paid. We also get financial support issues where certain vulnerable groups are not covered appropriately. We will also talk on cancer care, the backlogs, the issue of rural gaps, and the high-risk patients that may not get treated or get care where they need care, when they need care. The primary healthcare decline, we'll speak about how private healthcare is not adequately covering primary healthcare. And then on the outlooking issues, we'll talk on current issues that are in society. Basically, the context of how we operate is based on the South African dual healthcare system, where you've got a public healthcare and a private healthcare situation, with the public looking after about 86% of the public, and we're looking after the 9 million or 14% of the public. This results in persistent inequalities in access to healthcare of services, with the majority of people having to go to public facilities with all the challenges that they may face, including long queues, including inadequate facilities or resources. So as the regulator of private healthcare, our role is to promote and to protect beneficiaries of schemes, and also to align what we do with universal healthcare as currently in the form of NHI as currently legislated. As the chairperson has indicated, our priorities are to expand networks so that everyone is serviced. We've got underserved areas, so the designated service provider agreements that schemes get into with providers sometimes leave a challenge where people are far from providers who have been contracted by schemes. So our role is to try and expand those using legislation. We also exist to strengthen the enforcement of PMBs, which are mostly covering chronic conditions which people have, which sometimes results in complaints as to how those are handled in terms of payment, whether people are paid for PMBs or not paid for PMBs. We also promote preventative care through benefit design. What we've noted is that a lot of preventative care is not covered by benefits of schemes like vaccination screening, and if those are covered, they reduce long-term illness. Also, the issues of transparency in pricing and in the billing. The chairperson spoke about provider billing and the Section 59 report and transparency in billing. The issue she raised about the Department of Trade and Industry and Competition putting forward a proposal for a tariff negotiating platform is to try and deal with the issue of pricing as well as transparency in pricing. We also want to develop equity so that pensioners in the main and vulnerable groups are protected. So those are some of the priorities in our strategic regulatory framework. So currently, in terms of the gaps, as indicated earlier, we've got limited service provision in rural and underserved areas. Even in the private schemes industry, you will find that a lot of facilities are in urban areas, and people who may be on medical schemes or medical aid and are in far-flung areas and rural areas do not have access. And so that is one of the challenges. The main members may be in the towns, but the beneficiaries may be in far-flung areas. And so there's that issue of service provision in rural areas, in underserved areas, maybe like townships and other areas which may have difficulty to access. We also have shortages of providers and facilities, especially specialists. There are situations where certain provinces will not have certain types of specialists, or even public-private division of specialists, finding that the majority of specialists are in the private sector, and the state does not have that type of facility of specialists in the public sector. So some discussions to close that gap would need to happen so that the specialists are able to cover the whole health system and not only just the private or just the urban areas. We also have, because of this problem, it results in backlogs in specialist care, especially of people with cancer, causing illness to persist or to get worse because they are far from providers, and therefore they do not access them as fast as they get the illness. So that's one of the gaps that are there in the provision of healthcare. And as indicated earlier, if vaccinations and screening are not top of the beneficiaries that are offered by private healthcare or schemes, we get a decline in the primary healthcare uptake. And this has got long-term impact. For instance, if you do not prevent cancer, like the women have cervical cancer, and now there's vaccination for it. If not given, you expose women to cancers of the cervix long term. So those are some of the things we're punting for schemes to start including in their benefits. In terms of financial and social impact on patients, patients take medical cover so that they are free when they best need those covers. But what we see sometimes is that people have to pay out of pocket, and this increases the financial hardship at the time when people do not have money in their pockets or when they are ill. This results in insufficient scheme support for vulnerable groups as well. I've made an example of one group of cancer. I've also made an example of elderly people. You can talk of mental illness as well. Those are vulnerable groups of people that we need to make sure that they are financially and socially supported and not at risk when they best need the cover. And pensioners as well are at high risk due to age and comorbidities that come with age. So for a scheme to be well functioning, it requires social solidarity-based financial protection, meaning a mixture of young and old, a mixture of the rich and poor, and a lot of, so those types of mix require assist a scheme to have solidarity-based financial modeling. So that's what we promote among schemes. So the products that we see sometimes in the marketplace attract the young and leave the sick to be alone. And those schemes with only the elderly tend to be quite expensive. So our aim is to try and get a solidarity-based financial protection. So out-of-pocket payments in our last industry report, 2023-24, indicated that there were 43 billion was spent out of pocket, meaning that there were core payments and deductibles, meaning people had to pay part of the cost up front. Sometimes providers charge above what the schemes have agreed to with providers, and therefore there were tariff differences and people had to pay those differences. Certain treatments were excluded and not covered, and people had to pay for those treatments directly. And also sometimes you have a list of service providers you must go to, what is called a designated service provider. But because you are far from the service provider, you end up seeking help outside those service providers, and then you end up paying co-payment or out-of-pocket payment. And sometimes you reach your limits, members' funds are exhausted, and they end up paying out of pocket. Out of the 43 billion, we found that medicines take 35% of that amount, and the specialists 28%, the allied and health professionals 14%, and the general practitioners 9%, and then the rest of the disciplines 14% of that. As indicated earlier, the lack of focus on primary health care causes vaccination rates to fall, and preventative screenings are not done when they should have been done. You get an increase in disease burden due to late detection of conditions, and then you get greater long-term costs to healthcare. If you're not vaccinated and prevented, you are going to pay later with the long-term costs in the healthcare system. And then I've indicated as well a disproportionate impact on underserved communities. There are communities who go out when things are really bad. They don't go out because of distance, because of lack of providers close to them. So they only go out when it's really serious, and therefore the conditions get worse as well there. So the current benefit design are hospice-centric, and that's what we're trying to change, so that benefits focusing on hospitals and not primary health care. So our approach is to try and have a lot of focus on changing that setup. The PMB gaps as well, prescribed minimum benefit gaps, where there is limited cover for preventative. For instance, contraception is not on many schemes. So those types of things upfront should be included, need to be updated. We need to update the PMBs so that we use current evidence to include on what should be covered for PMBs. And current interventions, we need to expand as indicated, include primary health care, prevention and screenings, also develop guidelines based on latest evidence. In terms of designated service providers, this is an area where a lot of providers are unhappy because of unequal distribution of designated service providers. So this is one of the challenges in the industry which we are dealing with, where there are limited networks in less affluent and rural areas, where beneficiaries face high co-payments when DSPs are unavailable. So we get a lot of regulatory disputes around this, and access is limited, and issue of fairness as to which providers specifically. I'll use an example of pharmacies here. Local pharmacies are complaining that the schemes contract with big pharmacies, and therefore issue of fairness becomes a problem, and that is one of the issues we're trying to deal with. In our report on this matter of designated service providers, our research, it indicates that 67.9% of participating practitioners educate patients on DSP frequently or occasionally. And then 57% of participating practitioners do not update their patients regarding DSP conduct changes. And then sometimes we get, from experience, respondents see patients switching medical schemes due to DSP-related dissatisfaction. The prescribed minimum benefit related complaints are usually due to non-payments or short payments of those prescribed minimum benefits, and indicated as earlier on, DSP-related disputes as well are some of those problems, and clinically related complaints where formulary restrictions, your doctor suggests certain medication, but your formulary is limited and it gives you something that you're unhappy with. Or sometimes there's protocols that should be followed, but there's non-compliance with those protocols and something else is used, and therefore you have to pay maybe on the side, or schemes don't pay at all, or where there are coding issues or billing errors, and that creates a lot of complaints to us. or provider irregular billing, resulting in challenges between schemes and providers. And sometimes they limit disputes where there are limits or sub-limits as to you can only use up to this amount, and therefore that creates challenges for patients as well. We also have emergency disputes or complaints over what qualifies as a PMB emergency, disputes regarding diagnosis and treatment pairs, coverage. These we can give in detail if there is a question around it as to what that means. Coverage disagreements as well for chronic disease list conditions. We've got a list of conditions that are called CDLs, and sometimes your condition may fall outside this, and this causes a lot of complaints amongst members of the schemes. And sometimes you get delays due to outstanding or pending clinical documentation because either providers are busy or because there is just not access to giving us documents on time. And patients then do not get payment done or get access to the treatment they require. So the key risk factors in access care inequities are, as indicated earlier, there are conditions that are age-related, like men will have prostate cancer, and there are chronic conditions that are prevalent in the elderly. That's one group of conditions that are key risk factors in access. And then geography, as indicated earlier, the urban-rural disparity is another challenge that causes a lot of problems for us. And then the socioeconomic status affecting affordability is also a problem. And then the issue of providers, as indicated earlier, the shortages in low-income areas of providers, especially specialists. And then in the cancer environment, cancer affects the pensioners more or elderly more than the young people. And then there are limited oncology services in rural provinces. Well, not in rural provinces only, even in urban provinces, they are quite super specialists, the oncologists, and they may not be available easily. And then the delayed diagnosis and worsened outcomes resulting in serious problems of care. The high treatment costs of these of treating these conditions, and without adequate financial protection, it is a serious problem to deal with them. The current issues affecting the health system in general affects us, the private sector and the public sector. The health sector faces resource constraints. We've got chronic shortage of healthcare workers and specialists. We've got unequal distribution of services between the public and the private. We've got an overburdened public health facilities leading to long waiting times. And we've got reduced funding, especially for HIV and AIDS, as we know what happened to the American withdrawal of the funding for this program. The other problem is the human rights issues and access, barriers of access to quality for vulnerable populations, accessing healthcare. We also have limited healthcare access for foreign nationals, leading to social tensions. That is a debatable matter that we need to discuss how we deal with it because of the pros and cons of that problem. Then we've got an economic affordability pressure. The rising unemployment is affecting the affordability of medical schemes. The inflation and tariffs on medical imports are increasing the cost of medicines and devices. This is a matter as well that affects us and has a huge impact. The issue of tariffs has a huge impact on medicines, has a huge impact on devices that are for healthcare provision. I'm running very fast. I will take questions, Chair, if there are any questions. Thank you very much.
Thank you very much to the chairperson as well as the CEO. Honorable members, the presentation was presented to us. Can I get questions of clarity or comments, honorable members? Honorable Du Plessis, I see your hand is up. You can proceed.
Thank you, Chair.
It is. Thank you very much for the presentation from the Council on Medical Schemes. It's been interesting. There are a few questions that I have, and they surrounded, or they're around the idea that there are gaps here, there are issues here, but there are very little solutions other than sort of talk shops, if that makes any sense. One can't say on the one side we need a medical scheme that has a mixture of all people, but we are facing youth unemployment of 50% as a country. We can't say that we need healthcare that is excellent and good, and then on the other hand say our healthcare facilities are falling apart, which they are, and especially within the public sector, our hospitals and clinics do not pass muster, unfortunately. So my question is, yes, I understand it's a regulatory body, I understand it's an advocacy body, but what are the practical solutions that are being spoken about so that we can get affordable and unfortunately also, is there something like affordable medicine always, or are some procedures always going to be expensive? I'm just putting it out there as a question. But what exactly are we going to do to ensure that our healthcare facilities within the private sector or within the public sector, apologies, work well? There isn't a solution there. Also, there isn't a solution regarding the financial sustainability of a scheme, and I'm not too sure if that is the solution that's been put out there. I'm assuming. So if we could just have clarity on those items. Thank you very much, Chair.
Chairperson, I'm struggling to raise my hand, please.
Thank you, Honorable du Plessis. Honorable Sibande, over to you.
Yes. Thank you, Chairperson. I wanted to apologize, maybe to join you a little bit later. It's because I had a problem with the transport from Parliament. I was left behind, unaware. I was forced to reorganize my transport for myself. But nevertheless, let me go through this one. I wanted to commend for the presentation that, thank you very much for the presentation. It gives us a lot of highlights. That's for. But nevertheless, we'll go to question. Chairperson, my first question will start on, what is it? It will start on the primary health care, which is declining. And vice versa, the issue of people which are a little bit far from the resources, like in the rural areas. I wanted to if they can, the presenters can assist us to unleash it further, that so far at this moment, how many, a breakdown in fact, to give us a breakdown of how many people are they helping, or how many people which are not touchable, so that we can start it from that angle. Because also in their strategy, I'm subject for correction, they were saying that they are strengthening and reinforcing the primary health care. To me, it is a contradiction that you want to strengthen it while it's declining it. At the same time, there are people whom you know very well that are a little bit far from the resources in terms of the beneficiaries in a rural area. And then also, I need a clarity of that one, of the backlog of the specialist care. You know, there is this challenge of an argument that we are having a lot of doctors who are trained, which are staying home, which are not employed, etc., etc. While here we are struggling with this, I know that we are talking about specialists. That how do we get out from that one? because I know that maybe we're talking in terms of scarce resources, in terms of the doctors, in terms of specializing. And then also, there is a concern which I can't remember which slide, which says they are waiting for the bill in Parliament. I'm not sure which bill, because that one, it has sparked a question to me to ask that what is the relationship between themselves and the NHI? I know they spoke about it, but if they can elaborate more, because this side, it means that they can't do their work because of the bill which is still outstanding. So that is another thing which I wanted to clarify. And then also, we'll see, Chairperson, there is another contradiction from my side. It is a contradiction. Like, I'm subject for correction initially in input. They indicated how many funds how many billions they collect and what. At the end, they indicated some sectors are affected because of the thing which was done by the Americans. So, which is which? Because they do have any capacity to collect 1, 2, 3. At the same time, why must we depend on foreign aid all the time while we are able to fundraise inside the country? I'll put it there. Thank you, Chairperson.
Thank you very much, Honorable Sibande. I don't see any other hands of the honorable members. Is there anyone else? So there's no one. From my side, I will just want clarity in terms of slide 15, number 2, low cost benefit options. In the slide, the council indicated the Department of Health has opened the low cost benefits options report for public comment and invited stakeholders to submit their inputs by the 12th of May 2025. And beneath that is the Gauteng High Court dismissed. I just want to get clarity on who is the BHF and on what ground did they dismiss this application in terms of compelling the Council and the Ministry of Health to implement this low-cost benefit options. Chairperson, over to you.
Thank you so much, esteemed committee members and the Honorable Chairperson. Perhaps starting with your question, Chairperson, we've got a senior legal manager who can give us the background of who the BHF is. However, Chair, at a high level, the BHF stands for the Board of Healthcare Funders. This is an association whose members are the medical schemes. So the issue of the low cost benefit option is a long-standing issue that dates back to around 2017, 2018. The legal senior manager will give the background. However, Chairperson, this matter was dealt with by the Council for Medical Scheme, wherein we produced a report and handed over same to the minister in 2023, November, for his consideration and direction and guidance. Subsequent to us as the CMS handing over that report in 2023, the minister then published this report for public comments before he can make a determination on the content of the recommendations that are contained in the report. So we brought this to the committee to appraise the committee of the progress as it pertains to the low cost benefit options. Therefore, subsequent to that, Chairperson, then we had the BHF that serves as an association to protect its members, taking the matter to court, and the court ruled in favor of the minister. That is the high background information. However, later on, the legal and the executive managers could add to that. I am answering as it pertains to my presentation, Chair. The other question, Chairperson, related to when we deal with the key strategic issues, we then mentioned that we have the medical scheme amendment bill. The Honorable Sibande has asked that why are we awaiting the finalization of the medical scheme amendment bill whilst the nation is awaiting progress as it pertains to the national health insurance. The medical scheme amendment bill was put before Parliament many years ago. It is crucial for us because our primary mandate, Chair, to clarify the regulatory mandate is to regulate the private healthcare sector. I've had questions coming from the honorable members of the committee asking about the issues of public health and poor quality and infrastructure, and also talking to the issues of funding. However, our mandate, because we are created by the statute that was promulgated in 1998, our mandate is confined to the regulation of the private healthcare industry and not the public healthcare industry. The medical scheme amendment bill is crucial for us because we still have the 9 million people to protect in terms of the benefits, and the amendment bill captures some of the issues that we have raised in this presentation, i.e., the PMBs that do not cover all conditions and leave members of the scheme not fully covered. So the amendment bill, in one of its recommended clause, was to look into those issues and again to look at incorporating the primary healthcare package. So there's quite a number of issues that are of interest, particularly to the private healthcare sector, that is required to be addressed by Parliament by passing this bill so that the members of the medical schemes are fully covered and are protected. I would wish to then pass to the registrar. Yeah, I answered the issues surrounding the healthcare fallout within the public sector, and that is not within the scope and ambit of the regulator. We regulate the private and not the public health sector. The registrar.
Thank you, Chairperson. I'll ask some of my colleagues to come in so that you get to hear from a technical specialist point of view, solutions as indicated. What are the practical solutions for affordable medicines, as one of the questions is saying. The other question is about primary healthcare declining and access to resources and breakdown of people being access. I think it means we are not accessing people, and what are the solutions to access those people, and the issue of backlogs. I'll get Dr. Willie to just give a background and also give a background as to what the issues are around the LCBO, because committee may not be aware of the two parties in terms of what is the issue at hand, which made us go to court.
Yeah, all right. Thank you very much, Chair. But maybe let me start with the first question that was, good evening, honorable committee members. The first question was related to the issues of affordability. What is it that the Council for Medical Schemes is doing just to ensure that the medical schemes are actually affordable? And then I think the question was specific in the sense that it was saying what are the practical, real interventions that the CMS is undertaking. So there are a number of interventions as the office that we are undertaking. First of all, it is just to increase visibility of the work that the CMS is doing, purely from the complaints resolution perspective, just to indicate and maybe empower members of medical schemes to know what they are covered for so that at least they can interact with medical schemes better. Over and above that, we've got interventions where we produce guidelines that seeks to assist medical schemes in terms of capping contribution increase so that at least we ensure that contribution increase are affordable to members of medical schemes. So on an annual basis, we issue out guidelines to the industry indicating to medical schemes that they must try by all means to cap the contribution and align them to the CPI so that at least ultimately it is affordable to members of medical schemes. So those are some of the practical interventions that are at play. And then over and above that, we produce benefit definitions like the chairperson has indicated, CMS scripts. These are all done just to ensure that members understand and know what they are covered for. And then the other question was with regards to the balancing effect between the 230, the revenues, the amount of money that was collected by medical schemes, which is 227 billion rand. So the 227 billion rand, that is actually the premiums that members of medical schemes are paying so that at least they are able to access services. And then of that amount, about 90% of that goes to the actual payment of claims, which is equivalent to 218 billion rand that the chairperson was speaking to. So it's not necessarily related to the funding that is produced for HIV. So HIV, the committee members must remember that HIV is one of many conditions that are in the CDL list that are actually funded by medical schemes, right? But in the main, the funding from the United States actually supports the public sector over and above than the private sector. For the private sector is covered because HIV is actually part of the PMBs, right? So it's covered from that perspective. So the funding from the United States, from the public sector perspective, it's not the sole investment around HIV programs. I think government spends about 70% towards the HIV program. Then the balance is other funding that comes from elsewhere. And then really the drive is just to ensure that the social support across the fight and the battle against HIV. And also the fact that South Africa actually, HIV is more prevalent in South Africa compared to other countries. So there's this global drive just to ensure that we bring down the numbers. So the funding from the United States is also part of the global fight against the trend around HIV. So that is just the disparity there. So the 234 billion, it is just to fund all healthcare related services, right, in the medical scheme sector over and above HIV. But then the funding cuts, they mainly affect the public sector than the private sector. And then the other question was on was specific on the backlog. Again, the issue around backlog, it's centered around the private sector. A lot of it is specifically within the Gauteng region. If the committee members have been following what is happening in the media, so it mainly affects the public sector. But the big problem, it is a function of the fact that on how the specialists actually distributed, like the CEO was indicating, about 80% of the specialists who are treating cancer are in the private sector, right? And then the 20% are actually serving the public sector. So the drive here and the messaging that CMS is communicating is that we need to bring in the balance between the two sectors so that those who are practicing in the private sector can also assist the public sector so that at least we're able to minimize the backlog with regards to cancer care. And then the other question was with regards to the issue around the LCBO. The LCBO is what they call low cost benefit options, but the simplest term around it is like the low premium type of benefit option that doesn't necessarily cover your richer benefit. So as a result, it doesn't necessarily translate to good quality of care. The reason why BHF was compelling CMS to offer this type of benefit because BHF sees the market here. They see it as an opportunity to grow the medical schemes industry, right? But the bigger difficulty is that currently, the way it's shaped, this low-cost benefit option, it doesn't fully comply with the requirements and the stipulations and the regulations of the Medical Schemes Act, in a sense that it doesn't offer prescribed minimum benefit. And the chairperson did speak to about the prescribed minimum benefits, which is the essential cover that all medical schemes must cover, irrespective of a benefit option that you are in. It is just to ensure that schemes are able to provide the cover that limits the catastrophic financial impact on members of medical schemes. So we just need to ensure that whatever product is out there in the medical schemes sector, it firstly it complies with the Medical Schemes Act, and secondly, it's able to cover adequate care so that at least people are protected. They don't get to see themselves being exposed to out-of-pocket payments. I don't know what else, Chairperson.
Financial solution within the financial sustainability of the scheme. There's two ways to it. Financial sustainability, I think it's really the balancing effect of what members or the scheme is able to pay out, and also just to ensure that at least when the scheme is paying out claims, it also remains sustainable. So the office, what we have is we monitor this through our financial supervision unit with regards to Regulation 29, just to ensure that there's a benchmark that we can measure medical schemes to ensure that they are liquid, in a sense that they are financially sustainable, which is solvency. The solvency ensures that medical schemes are able to keep 25% of what they collect, which is the contributions, in reserves, so that at least if there are catastrophic events, medical schemes are able to honor those claims. So we've got a number of measures to ensure that there's a balancing effect. Firstly, medical schemes must be able to pay for claims, but at the backdrop of that, they must be able to ensure that they are financially viable. And then in doing so, some of these are actually monitored and managed through the prescripts of the Medical Schemes Act. So there is that balancing effect between the two.
Last matter was the breakdown of people being accessed.
Yeah. So the chairperson indicated to about 9 million lives that are enrolled with medical schemes. So by virtue of what is contained in the Medical Schemes Act, that is the population that we protect as the regulator. So, and then in one of the slides, it does give a breakdown of where most of these members are located. I think about 9% of the members are actually located in Gauteng, and then about the second proportion is in Western Cape, 16% is in Western Cape, and then there's also another percentage, a bigger percentage that is located in KZN. So obviously not all these members do complain to the regulator, because it could either be a function of awareness, some may not be aware of the regulator, or some of them, they have got other options of complaining. For instance, there's a provision that medical scheme members can actually complain directly to the scheme. So as a result, they may not all of them complain directly to the CMS, because schemes also have got complaints resolution processes to ensure that those members actually get the services that they need. So in our report, Honorable Chairperson, we do give a breakdown in terms of how many members actually complain to the regulator and the types of complaints that we do receive. And then also, even in terms of the Medical Schemes Act, it makes provision in terms of how soon should a complaint be resolved when it's received by the office, just to ensure that a member of medical schemes is able to get adequate treatment, and even if it's an emergency, those patients are able to get access to care. So there's a breakdown. We can make that information available to the honorable committee members in terms of the breakdown of complaints, so that we can get a sense in terms of how many members do we us as the office service. But in the slides, the chairperson did give an indication in terms of the direct, the direct access to members in terms of the consumer education drives and sessions that we undertake as the office, and also some of the average number of calls that we get, so that that gives us a direct access to the members, that indicating we are, as the regulator, accessible to members of the medical schemes.
Yeah, I think the last question from Member Sibande was about the contradiction that we say we are short of specialists, whereas in the public domain, there is an outcry about doctors who are not employed. I think the issue, as he indicated later on in his contribution, this is mostly about the young doctors, usually who have finished training, who need placement in order to start their career I think those are public health issues that require budgeting in order to deal with them. Whereas the issue we're raising, it's about highly qualified specialists who are required for conditions, for instance, cancer treatment and rural areas where the population does not get those kind of assistance from those types of specialists. But it is a challenge that requires funding of the health system in order to be able to make sure that all doctors are allocated in the system. I don't know, Chairperson, if you need to.
No, thank you, Chair. If there are any further questions, Chairperson will guide.
No, thank you, Chairperson. I think all of the questions and the comments you have responded to, but I will just request the council to just make that information regarding the patients and the breakdown available to the committee, so that we as a committee can see what is happening there, especially the patients or the beneficiaries that is in the rural areas, because that is a really big concern. So from our side as the select committee, we really appreciate your responses as well as your time in terms of presenting and responding to the questions of the honorable members. So thank you very much, Chairperson and your team. We really appreciate it. If there is anything else, we will surely do it in making a request in the writing to your office. So thank you very much. We release you as the council so that we as the committee can proceed with our meeting. Thank you very much, Honorable Chairperson, as well as the team.
Thank you so kindly to the Honorable Chairperson and the astute committee member for the opportunity to present to yourselves. Indeed, Chair, we are available to assist your committee with any information that will assist you in executing your own mandate where you are. And this team behind me will indeed reach out to your office, or whenever your office reaches out to us, the team will indeed respond positively to ensure that the committee receive the necessary information that will assist them to apply their minds and make the necessary recommendations to the leadership and their principles that they need to recommend to. We want to thank you for the opportunity and wish the entire honorable committee a very good evening.
Thank you very much, Honorable Chairperson. You are released now.
Thank you.
Thank you. Right, switch off.
I'm going to switch off the speaker.
Marcel, you can flag the agenda.
Yeah, Chair, I was just waiting for them to stop sharing. I'll flag the minutes, Chairperson.
No, it's fine, Marcel. So, honorable members, we now at the point on the agenda where we must adopt the minutes of the 3rd of September 2025. Can I get a mover for the adoption of the minutes? Honorable Du Plessis.
Chair, I move to adopt the minutes.
Thank you very much, Honorable Du Plessis. Can I get a seconder?
Honorable Sibande, I move for the second.
Thank you, Honorable Sibande, for seconding the minutes. We are now at the point where we will get an update on the study tour. Over to you, Marcia.
Thank you, Chairperson. Good evening, members, colleagues. Again, Chairperson, I'll just give a short update of where we are in terms of the study tour.
You may proceed. You may proceed.
Yes.
Marcia.
Chairperson, currently on our program, we have just come from an oversight, and this term has just ended. This is our last meeting for the term. In the coming term, the fourth term, there is the issue of dealing with departmental annual reports. Then we also have another proposed oversight. Part of our program includes the health infrastructure chair as the oversight issues. Then there is a taking Parliament to the people as well, scheduled for later on in the fourth term. So as it stands now, Chairperson, unfortunately, our program for this year does not accommodate us to plan for us to do a study tour, but we are planning to in the early first term, Chair, there would be some time to then propose and work on a study tour. So the date would be the first term of 2026. Thank you, Chair.
Thank you very much, Marcia. Honorable members, the update from the Secretary of the Committee. Is there any comments in terms of that? Because I think the next proposed date, it must be in the first term before March 2026. Honorable members, anything from your side? I don't think so. So, honorable members, let me thank you all for availing yourself for this meeting in the after hours on this Wednesday night. So thank you very much, honorable members, as well as the staff that is supporting our committee. Thank you very much for your time as well. So, honorable members, this meeting stands adjourned.
Thank you, Chairperson.
You must enjoy your evening further. Thank you.
Bye-bye, Chair. Bye-bye, colleagues. Have a wonderful
you.
evening.
Thank you.
Lekker, Chairperson.
Yes, Honorable Sibande.